So moving on to our second last session for this afternoon, which is on lived experiences and perceptions of palliative care among advanced HIV patients to a qualitative study from Bihar, India. Although explicitly recognized under the human right to health, with a few exceptions, palliative care is not incorporated into the healthcare system in LMICs. Each year, an estimated 40 million people require palliative care, 78% of whom are based in low and middle-income countries. This session will explore some of the belief systems around dying, palliative care, and of life care among people living with HIV and their caregivers. I want to invite Mr. Nair, a social research scientist with the King County Department of Public Health in Seattle. Welcome, Mr. Nair. Please do bear with the interruption of 5 minutes heads up. You may start your presentation now.
Thank you so much for that kind introduction. Good morning to all of you, bright and early from Seattle, Washington. My name is Mohit Nair, and I've worked with MSF OCPA for several years in qualitative and mixed methods research on topics ranging from antibiotic resistance to HIV Kala Azar and palliative care as well. Today, I'll be speaking to you about the lived experiences and perceptions of palliative care among advanced HIV patients in Bihar. And this will be a qualitative study and a timely and key area for OCPA in India. So for starters, according to the National AIDS Control Organization, the 2017 adult HIV prevalence in India is estimated to be around 0.22%. Now, Bihar has a population of roughly 110 million people, and it actually is one of the largest and least economically developed states, and also one of 6 states where AIDS-related deaths continue to rise. So in Bihar, in this context, MSF provides dedicated and holistic inpatient care to acutely unwell people living with HIV/AIDS, also known as PLHA. This is a vulnerable cohort of patients who are severely stigmatized and routinely denied access to care. So when we talk about advanced HIV, what do we mean? Well, it's defined as by the World Health Organization as a CD4 cell count less than 200 or a clinical stage 3 or 4 event, such as Kala Azar. These patients often have a high mortality rate between 30 to 40%, and it's important to note that there are very few research studies of palliative care in this context. So given the limited studies that we see from lower and middle income countries, particularly with this vulnerable cohort of patients, it's important to note that we could find no studies in India at all. Most of the palliative care studies that come from India focus on cancer care in southern India. Given this context, our study actually served a unique niche and aimed to understand how PLHA and caregivers of hospitalized patients view palliative care and end-of-life care, uncover their expectations from healthcare providers, and 2, uncover how the dying process is experienced by other patients and relatives of deceased patients. Our study was approved by the MSF Ethical Review Board and the Ethics Committee of the All India Institute of Medical Sciences in Bihar, in Patna, and that was an important partner for us in the study. So how do we actually go about doing this? Well, we utilized an exploratory qualitative study design with semi-structured in-depth interviews and 1 focus group discussion. The study population as a whole comprised of 10 recently discharged PLHA, 7 relatives of deceased patients, and 5 caregivers of hospitalized patients who were being treated at the time of study in the MSF-supported advanced HIV inpatient ward at a government secondary care hospital in Patna. In addition to this, we also talked to 7 key informants from community-based organizations that worked on either HIV or palliative care, and we included them in the sampling frame for a total of 29 participants. Data collection as a whole took place over a 1-month period in 2019 between April and May. All interviews happened face-to-face with an audio recording after obtaining written informed consent. Data was transcribed verbatim from local languages such as Bhojpuri, Maghi, Maithili, or Hindi, and then translated into English and entered into NVivo 11. And then 2 researchers, one from AIMS Patna and myself, we read and reread each transcript, engaged in the 3 steps of open, axial, and selective coding as part of an overall grounded theory approach to conduct more of a thematic analysis of the data. And important to note again that all participants did provide written informed consent prior to participation. So that being said, what did we find as a result? Well, one of the most prominent themes was the fact that there was this fear of dying. PLHA who were critically ill and several relatives of deceased PLHA definitely preferred to have a separate room for dying PLHA, as many had witnessed deaths and expressed discomfort with the process. Some patients felt like dying patients made them even more nervous. As one said, it causes a lot of fear and concern when you look at those patients. The ones who are healthy will also become anxious. This was by a male age 44 who was a patient in the ward. This particular patient's wife also reported that she usually shielded her husband from news about other deaths in the ward in order to keep him motivated to keep on treatment. However, the prospect of separation also brought about concerns of social isolation and the potential for ignorance or lack of attention among patients who had known others that were admitted to separate rooms. This is both from staff and from patients. So one person said, if they're separated, it would be difficult for us to meet and give them companionship. Only doctors and nurses will visit them. It's nice the way things are because they talk to me and I talk to them. If someone has to stay alone in a separate ward, then you feel isolated and the heart feels uneasy. And this was a woman who is age 21 and a patient again in the ward. And, a separate space, there was some concern that this was seen as a place for very helpless patients. Some patients are kept who are in the last stage of the disease. So that would be something that would have to be weighed if a separate room is considered for palliative care patients. Another prominent thematic that we found was that there was in general a very interesting discrepancy between what PLHA perceived and what relatives of deceased patients wanted when it came to disclosing a terminal prognosis to dying patients and their caregivers. So what do we mean by this? Well, many PLHA who had been critically ill themselves reported that a transparent disclosure of prognosis to dying patients would make them anxious and could actually harm them, and that this should never be done. Instead, respondents claim that the prognosis should be disclosed only to family members. So as another male 40-year-old patient said, it would be better if only the family members are informed and not the patient actually. The patient will pass away just hearing the news. Now, this is what we heard from the patients, but if you talk to the relatives of deceased patients, on the other hand, many of them deeply regretted not having had meaningful last moments with their loved ones before their death. Many perceive that the prognosis should be disclosed so that the patient has a chance to meet loved ones. As the person on the screen says, the only thing that makes me sad is that I was not informed beforehand of my mother's condition. If I knew ahead of time that she was going to die, I could have let my sister talk to my mother on her deathbed. So this is again sort of alluding to a sense of regret and a lack of time with folks who are on sort of end-of-life care. In general, it was pretty clear among patients that there was very little awareness of palliative care, even among more educated patients. When we probed about the course of treatment, however, we sort of broke down the different components that come as part of palliative care. Some patients still reported being illiterate and ill-informed. I'm illiterate and haven't studied anything, so what will I understand? This was from a caregiver, a woman who was age 35. And here, this speaks to this internalized sense of a lack of agency among the respondents. But again, when we probed on a little bit more on the different factors that go into palliative care, patients prioritized A, getting medicines on time, B, food, and then also accommodation. So as this quote says, most important of all, the patient should get medicines in a timely manner, treatment should be done well, lodging and food, all these facilities should be good. And interestingly, despite the fact that we're talking about patients who are either on palliative care or end-of-life care, they did think that a full recovery was deemed most important regardless of the prospect. So there was this expectation to continue treatment. In general, patient deaths tended to be quite traumatic for other PLHA, which supported the earlier thematic detailing the need for a separate palliative care area. There was limited space in the ward for grieving relatives, and some patients felt like they were often rushed from place to place when the relative was passed away. So as another sort of teenager said, like when he died and then and there within a few seconds, they called an ambulance and sent him onward to his home. They were only concerned with whatever paperwork was required to be done. They hired and paid the ambulance and turned them away from there. And here you can see that many relatives were also reporting that they really wanted a little bit more time to basically spend time with loved ones. Some were screaming in grief in the hospital, and usually they were whisked away to another room away from the patient, and there was very limited time to grieve and limited counseling support, at least during the time of the study. Meanwhile, other PLHA who were in the facility would also admit that they became anxious upon hearing these cries, and they tried to console the patient who was crying. And it's important to note that, while this is the context in MSF, the situation in other government facilities in Bihar, non-MSF facilities, was actually far worse. Patients often reported being asked for bribes prior to being able to sort of see their patient, and they were often completely ignored by hospital staff. So the broader situation sort of warrants a lot more scrutiny as well. In terms of hospital-based patients, we saw that there is definitely a need for greater social support. many patients reported that they were socially isolated and bored after several days of admission. As this woman says, "We do nothing all day. When my husband comes and visits, I smile and laugh with him, but when he returns home, I feel all alone. My father is there and I can't speak that much with him. I don't know. Everything is good, but I get a little bored here." Another said, "The options are limited. I'm confined to my bed all day long. If there are loved ones nearby, then sometimes I chat with them. Sometimes I take a walk along the corridor." When asked what could be provided to help pass the time, many patients again hesitated to answer, alluding to that sort of lack of agency that patients often feel. Some said, this was a hospital and not a place for entertainment, and that they had no such expectations from their providers. After some probing again, however, some patients suggested that perhaps a television or space to walk around, or even something as simple as board games, could be provided to make the spaces a little bit more patient-friendly. And finally, we saw by and large that there was a preference for dying patients to be sent home with medicines and proper guidance to be able to see their relatives. Patients perceived that they should be given financial assistance and a vehicle to return home and be with family members, especially in those last moments. And as we know, in sort of accordance with local and religious customs, relatives and patients alike have generally a preference for home-based death. This is shown in the literature as well. And so there's this preference over home death over hospital-based deaths. And that's because certain rituals need to be followed. So for example, in Hindu tradition, the body is typically cremated and followed by a mourning period. And so, one patient told us what happens here is that we go and we collect the sticks, we burn the body, and this is what we do for final rites. And after 13 days, there's another ritual for death where we feed the priests, we call the villagers and we feed them. And these are the rites that are followed. So it's kind of a process that is holistic and does involve, it's a social phenomenon. And that's kind of what drives this process of asking for a home-based palliative care plan. So if you take our findings sort of in concert with one another, you can see sort of what the situation is like for palliative care in India. And we know that palliative care programs have been limited thus far to cancer care and treatment, and service provision has also been largely done by CBOs or NGOs. When we look at this vulnerable cohort of advanced HIV patients, they have complex care needs. That much is very, very clear. They require supportive palliative care services, which go far beyond pain management and include actually exploring the patient's understanding of illness and prognosis, psychosocial support for patients and caregivers, and advanced care planning. Another sort of
5 minutes, sorry.
Yeah, thank you. And another sort of interesting point here is that there's notable differences in cultural norms and practices with respect to death and dying, especially when we look at patient-centered versus family-centered decision-making. When you look at Western bioethics, it often values full disclosure between the doctor and patient, but other cultures may not be so welcome to this kind of transparency. And having said this, we should not make assumptions about what information a patient wishes to receive about their condition or prognosis based on cultural background. It's difficult to predict an individual's preferences, so that should be part of the care plan. We need to discuss how much and what type of information each patient and family members wish to receive. So in order to improve care and treatment for critically ill PLHA, palliative care should be introduced and discussed early in the care plan by a holistic team of providers that's aware of patient history. You should create a separate tailor-made area for palliative care patients that address the specific needs for this cohort, and extra care should be taken to ensure that patients and caregivers are regularly visited and social activities are provided to prevent isolation. The grieving process should allow patients to spend time with their loved ones, perhaps in a separate room, without being cognizant of sort of not to rush them toward an ambulance, as one patient said. And finally, we need to greatly expand home-based palliative care programs, both from an advocacy standpoint and whatever we can do in our own programs, in order to respect the needs of terminal patients and relatives, many of whom prefer these home deaths over hospital-based deaths. And based on the findings of our operational research, it's important to note that the program already made changes. A separate space was created for palliative care patients. We prioritize social well-being and privacy for patients. We really prioritize mental health counseling and support. And there was a more of a holistic focus on spiritual care since these needs were identified from the study. Now, despite the broad variation of participants in the study, there were a few limitations. Recall bias may have played a role in accurately describing the encounters with hospital staff, particularly for the relatives of deceased patients. And secondly, while we achieved saturation in the study as a whole, it was not true in each analytical subgroup, and geographic coverage and sample size was limited, given that this was a qualitative study. So, in conclusion, we see that there's a need to improve palliative care provision in Bihar, particularly for advanced HIV patients, patients on end-of-life care may benefit from a separate area with adequate psychosocial counseling, and it's crucial to understand how patients want information to be delivered, whether they want to delegate this decision-making to family members, and really for care teams to gauge how much to involve family in the treatment plan. I'd like to end by just mentioning that we are currently in the middle of a pandemic that, fortunately or unfortunately, will make us all rethink how we approach palliative care. Basic palliative care training to all medical and nursing students has been the call and recommendation of the palliative care community for many years. And had it been heeded, the healthcare workforce would probably be much better prepared for the pandemic as a whole. For this study, I'd just like to thank all of the different teams at MSF and our partners at AIMS and all of the research interns who helped us with the transcription and translation process. Thank you so much.
Thank you so much, Mr. Nair. That was a captivating presentation. So we have a couple of questions from our attendees. So this is from an anonymous user. Thanks, Dr. Mohit. Can public-private partnership with civil society or counseling organizations help in reducing burden when government support infrastructure is limited?
I think that's absolutely the need of the hour, right? There's other unique models out there that need to be explored. As I mentioned, thus far, even in places outside Southern India, wherever there is palliative care, it's been through CBOs and NGOs. There's sort of Pallium India. There's different organizations that are coming in to meet this gap. And MSF has actually done the same thing in Bihar. We've acknowledged that this vulnerable cohort of patients needs care and treatment. And so that's exactly what we focused on.
Thank you. So this is from Gurpreet Arora. Hey Mohit, interesting study. In your analysis, was there a major difference in the perception experience of palliative advanced HIV patients versus patients receiving palliative care due to any other cause such as cancer?
That's very interesting. Actually, so because we focused on the secondary hospital, that's an HIV inpatient facility, we were only looking at HIV. So we did, as part of my study, I did visit, Mahavir Cancer Center, and I saw what the situation was like there, but they weren't formally included as part of the study. So we did focus only on HIV.
Thank you. This is from Sana Beg. Thank you, Dr. Nair, for your presentation. Given that palliative care, end-of-life care is a relatively new concept in India, were there any learnings during the course of your study that could help improve the receptiveness and overall approach to palliative care in the country?
Yeah, I mean, I think again, move beyond cancer, I think is one thing, right? We know with the pandemic, again, there's needs that have come up as part of COVID. There's needs that have come up with other diseases. There's many end-stage diseases where sort of palliative care lags in India. And so it's clear that there's a need for advocacy. I think in MSF specifically, what I have loved is sort of the focus on advocacy. And I think we need to work more with the different stakeholders at the state level to really focus on providing this kind of palliative care and making it part of the care plan. I know it's been part of the National Palliative Care Program. There have been funds set in place for different states to apply, but I think in the context of Bihar and other states, we need to just encourage states to move forward with that. And in the meantime, of course, we're working to fill the gap and provide services.
Definitely. So this is from Dr. Rehan. Can't a patient be taken at home with palliative care when medical caregiver has not a lot to do for a patient at hospital?
Can you repeat the question?
Sure. Can't a patient be taken at home with palliative care when medical caregiver has not a lot to do for a patient at the hospital? So basically you take them to home because of the poor service.
Yeah, there's actually, I mean, right now that's not possible given the sort of advanced care needs that are in place, and even actually in sort of well-established cancer centers like Mahavir Cancer Care, there are restrictions on sort of who can get access to morphine. So there's opioid availability issues. There's sort of who can actually come and refill the medications. There's these things that need to be sorted out, and with HIV, that's definitely not in place right now.
Thank you. So this is one last question because I know we're running out of time. So this is from Kalyan Krishna. Very relevant and interesting study. Does application of person-centered care rather than patient-centered alone address someone of the outcomes of the study? I'm sorry, I'm a bit unclear there. For example, support to caregivers, patients, and families. Do you want me to repeat?
I think that's absolutely important. I think that's the key here and kind of the goal of this session too, right? To think about person-centered care. We need to make this as person-centered as possible. I think that's where the study came into. It's about sort of addressing the needs of the people who are part of the care process, right? It's not just the patient. It's also the relatives and the family members that have been involved in this process, because that grieving process is sort of experienced by everyone as a team.
Thanks, Mr. Nair. There is an existential question, and I would like you to take it in the networking lounge if that's okay. And once again, thanks so much for weaving such a heart-rendingly riveting tale around the profound yet crucial caring approach to improve patients' quality of life and their families and address their suffering. Thank you so much.
Thank you for having me.